Hey everyone, and welcome back to The Explainer. Today, we're tackling a topic that, honestly, usually gets reduced to a quick punchline or, that fast-talking warning at the very end of a late-night TV commercial. We're talking about Priapism. But look, if we just push past those pop culture jokes for a second, we're actually looking at a really complex, incredibly urgent urological reality. So today, we are going to completely demystify this condition. We'll break down exactly what is happening anatomically and look at how medical professionals actually manage it in real time. Okay, let's dive into this by looking at the strict clinical definition. Because priapism isn't just, an erection that overstays its welcome. It's officially defined as a persistent penile erection that continues for more than 4 hours in duration, completely independent of sexual stimulation. And guys, that 4-hour mark, it's not arbitrary. It's an absolutely critical threshold where irreversible tissue damage really starts to accelerate.
So, here's our roadmap for today. We're going to define the condition, look closely at the ischemic emergency, make the diagnosis, walk through the stepwise treatment, and then finish up with the non-ischemic and stuttering types. Section 1, defining the condition beyond the basics. Over 95%. I really want you to think about that number for a second. That is the staggering proportion of all priapism episodes that are classified as ischemic. Getting this stat right out in the open is huge because it instantly highlights the overwhelming primary threat we're dealing with. Basically, almost every single time a patient walks through the ER doors with this condition, they're facing an ischemic event.
Section 2, the ischemic emergency, a race against time.
To really grasp why this is such a ticking clock, you've got to think of ischemic or low-flow priapism kind of like a clogged drain. You've got decreased venous outflow, meaning blood gets pumped in, but it literally cannot get out. This creates a stasis, a total standstill of trapped, stagnating blood. And without that fresh circulation, the local tissue rapidly develops hypoxia, meaning it's starved of oxygen alongside severe acidosis. Clinically speaking, the corpora cavernosa becomes fully erect, highly rigid, and incredibly tender to the touch. That trapped, oxygen-starved blood is literally choking the tissue, which eventually leads to progressive smooth muscle necrosis. Dead tissue, basically. So what exactly happens when you starve this incredibly delicate tissue of oxygen for too long? Well, the consequences are brutal. Early intervention is absolutely crucial here, because if that erection is present for more than 12 hours, erectile dysfunction can occur in up to 50% of cases. And if that clock just keeps ticking, by the time a patient hits that 24 to 36-hour window, almost 100% of men will develop severe, irreversible ED. The tissue literally turns to scar. Section 3, making the diagnosis, essentially solving the case. And this brilliantly illustrates what the doctor is looking for, because there's a night and day difference in presentation. The ischemic emergency, like we said, is super painful, highly rigid, and if you draw blood, it's this remarkably dark, deoxygenated color. Now, in stark contrast, the non-ischemic type, it's usually totally painless, it might fluctuate or only be partially rigid, and the blood is bright red. Why? Because normal or even high blood flow is still happening. But to definitively solve the case, we can't just guess. We rely on very specific diagnostic clues. By aspirating a tiny bit of blood and running a gas test, we get the hard metrics. Ischemic priapism will show a PO2, so oxygen level, of less than 30, a high PCO2 of over 60, and a really acidic pH under 7.25. Doctors will also use a color Doppler ultrasound to confirm that blood flow is either super sluggish or just non-existent. It's these hard numbers that instantly separate a true medical emergency from a non-emergency. Section 4, stepwise ischemic treatment, or as I like to think of it, diffusing the bomb. Once that emergency is confirmed, the medical team has to act fast. The protocol is a really rapid stepwise approach. Step 1, administer local anesthesia and insert a wide-bore needle, usually a 16 or 18 gauge, straight into the corpora cavernosa. Step 2 is corporal aspiration, basically physically pulling out all that dark, stagnant, acidic blood. And step 3 is cavernosal irrigation. They flush the tissue out with sterile normal saline to dilute whatever stagnant blood is left behind. Now, what's really interesting about this slide is what happens if that initial aspiration and washout just doesn't work. That's when we turn to meds, and the precision required here is fascinating. The first-line therapy is injecting a sympathomimetic drug, something that forcefully constricts blood vessels, usually phenylephrine. The doctor injects tiny little allocorts every 3 to 5 minutes until the erection goes down, but they are capped at a strict maximum of 1 milligram per hour. And because this kind of drug can seriously spike your blood pressure, strict cardiovascular monitoring is an absolute must for at least an hour, especially if the patient has any history of heart issues.
But what if medical therapy completely fails? Well, then we have to move to the surgical algorithm. If the erection is still persisting, surgeons will actually create shunts to physically force the trapped blood out. They usually start distal, right at the tip of the penis, like a T-shunt. If those less aggressive distal shunts fail, they move up to proximal shunts. And listen to this. If the patient delayed coming in for more than 48 hours, or if an MRI shows the tissue is already totally necrotic, they bypass the shunts entirely. The algorithm routes them straight to a primary penile prosthesis implantation.
Section 5, Non-Ischemic and Stuttering types. Okay, so that was a super intense protocol. Let's take a breath, slow our pacing down a bit, and look at these alternative presentations. Let's look at non-ischemic or high-flow priapism. If ischemic was our clogged drain, non-ischemic is basically a leaky pipe. This is almost always caused by some kind of blunt trauma to the penis or perineum. That trauma tears the cavernous artery, creating a fistula, a little abnormal connection that just dumps fresh, highly oxygenated arterial blood right into the tissue. But here's the kicker. Because that blood is full of oxygen, the tissue isn't starving. So it is absolutely not a medical emergency. In fact, astonishingly, about 62% of these cases will just resolve totally on their own without any doctor interfering at all.
However, if it's just not fixing itself and the patient really wants it resolved, there's a conservative ladder we can climb. Step 1 is expectant management. Think ice packs and perineal compression. If that doesn't do the trick, step 2 is arterial embolization. Radiologists will try to plug the leak, preferably using absorbable materials like an autologous blood clot or absorbable gelatin so it doesn't cause permanent damage. And finally, if embolization just keeps failing, surgeons can go in for a definitive surgical fistula closure. Now, the very last variant we need to understand is stuttering priapism. This is defined as recurrent ischemic priapism that happens over an extended period of time. Make no mistake, though, each individual episode is an acute ischemic emergency. The doctors have to use the exact same diffuse the bomb, aspiration, and injection protocols we talked about earlier. And it's worth noting the most common underlying cause for this awful reoccurring nightmare is sickle cell disease.
So, the crucial point here is prevention. Because these patients are facing recurrent emergencies over and over, we have to manage the underlying physiology to stop the episodes before they even start. Options might include hormonal therapies like LHRH agonists for adults, which actually suppress testosterone, or they might use PDE5 inhibitors. But, and this is a huge but, those must absolutely only be started when the patient is completely flaccid. Otherwise, they can use other daily meds like digoxin or gabapentin to try and keep those frequent relapses at bay.
And that leads us to our final thought for this explainer. When we step back and look at patients managing chronic, lifelong conditions like sickle cell disease, how can implementing these preventative stuttering priapism strategies ultimately change the trajectory of their long-term quality of life? It kind of forces us to push our perspective way past the panic of the emergency room, right? It reminds us that successful medical management is really about securing a patient's future well-being. Thanks so much for joining me today, and as always, keep exploring.